So let's go through and talk about some of the secretion mobilization techniques that are in your packet. First talk about a cough. There's three phases to the cough, as you see. First, the person takes a deep breath in, brings the air in. They close their glottis to increase pressure to prevent the air from leaving. Then they contract their abdominal muscles to cause an increase in pressure in the pleura and the pulmonary space. And then we hit a point where the pressure is greater than the pressure that the glottis can hold, or we relax the glottis, and that causes that force or that cough and causes the stimulant or the irritant or the secretions to be pushed out of the lungs. Understand that a cough is only going to clear the secretions in the main stem bronchi, in those upper airways. It's not removing secretions from down in the periphery. Okay, so what can we do for this as an intervention? We can sometimes just tell a person they need to cough. Sometimes people are hesitant to cough. They're worried that it's not polite to cough. And, you teach them how to do it, how to cover their mouth, how to do it in a hygienic way where they're not spreading germs, of course. But some people just need that cue. Cough harder, breathe harder, take a deeper breath to do it. Also understand breath stacking can be a good thing that we teach. We have the person take a small breath in, small breath in, small breath in, small breath in, and then cough. That can help teach a person to take a deep, bigger breath before they cough. You see some of the precautions are in your handouts. These aren't major precautions, just things to be aware of. We might assist somebody in a cough, and it looks a little bit like a Heimlich maneuver, right? Where we push down their abdomen, we stand behind them, and as they take a deep breath in, and right before they cough, or as they're trying to cough, you give a forceful push upward, uh, pushing up into the diaphragm in a sense to cause an increase in pressure to help them with the cough itself. This is an uncomfortable thing to have done for the patient. This is most appropriate when someone had a spinal cord injury and they're not going to be able to feel it. Okay, so your average, person who just has a cough, this is not something you want to do. Your person has sensation in their abdomen, this is not something you want to do. FET or a huff cough. So this is a modification of a cough, okay? But it's done in a way where the glottis stays open. You take a breath in, you make an O with your mouth, and you huff the air out, okay? You're trying to force the air out in that way, but you do it in a way that keeps your glottis open. If you take a deep breath in and then huff it out or do the FET, it gets the secretions in more the peripheral areas of the lungs. And think about what we talked about before, regional differences in the lungs. That makes sense, right? Because I take a breath in, where does the air go first? It goes to the periphery or the distal part of the lungs. So deep breath in, huff, it's more the peripheral secretions. And then more of a smaller breath, you're going to take more of from the proximal areas. You see the comment about the chicken wing. We'll practice that in lab. I did give you a link in your handout to go watch this in action. I would encourage you to watch this before we have lab so you understand a little bit more and try this at home before you go through and come to lab where I practice it. Active cycle of breathing. This and autogenic drainage are a little bit more of a complex breathing strategy. It's just something that should be reserved for a person who has long-term chronic secretion issues. So your person with cystic fibrosis, your person with bronchiectasis, your person with chronic bronchitis who has a lot of secretions. This is not something you would necessarily teach to someone who just has pneumonia and just has this short-term need for secretion mobilization. I usually advise it's better to start with the FET, have the person learn the FET first, make sure they can do that appropriately and get results of that, and then you can build an active cycle of breathing and autogenic drainage. So it's active cycle of breathing. You go through different sizes of breaths or depths of breath to move secretions from the smaller to the large airways. So what you do, you first start with breathing control, just gentle breathing in and out, relaxation, and you're kind of just sighing the air out. Phase two, you take deeper breaths, you do those end inspiratory holds, you let the air out. We'll put things together a little bit later. You could have the person do this in a side lying or a prone position or a supine position and you could provide percussion and vibration at the same time. So the idea is this loosens the secretions, kind of gets the air in there, loosens them up, and then you go on to phase 3, the FET. So this is what I mean. You want to make sure the person can do the FET before you teach active cycle of breathing. So you take a couple deep breaths, or I should say smaller breaths first to get secretions from the more distal areas, and then you build up to more fuller breaths to move it from the more proximal areas. There's a lot of variability in how you do this. The person kind of learns how many breaths they need to take, how many huffs they need to take, how often they need to go through that cycle. It's called active cycle of breathing for a reason. So they learn how to do this. And you see as you go down the cycle here at the bottom, right? The breathing control, FET, you're cycling back and forth to help move those secretions up. Autogenic drainage, similar concept, focuses, moving the secretions from the smaller to the central airways. Phase 1, slow breathing at the low lung volumes. You're trying to get the air in more of the distal areas. Phase 2, you're working up to mid-range. Phase 3, you're going through and using those FETs. Okay, so I think about it this way. Normal, you kind of have the person first take a couple breaths to begin with, and then you move into the unsticking phase, okay, where they take kind of a deep breath in, smaller breaths there, and then you move into the collecting phase, okay, where you have them take deeper breaths, hold it, deeper breaths, hold it, and then you're moving into that evacuation stage. So small breath, huff, small breath, huff, small breath, bigger breath, huff, big breath, huff, and then you're typically going to finish it up with a cough at the end to bring those secretions up. Okay, postural drainage is the next one. I have a ketchup bottle because if you think about how do you get ketchup out of a bottle, you put it upside down. You put it in a dependent position to allow gravity to bring that ketchup up. Same thing here. Passive techniques, you put them in different positions to help use gravity to drain the different segments of the lungs. And this is why it's important that you know your segments of the lungs for postural drainage. Do you need to memorize every single position for postural drainage? I would say no. If you know your segments, if you know your anatomy, you can figure out that if we're talking about the left lung, posterior segment of the lower lobe, you can think through that and say, okay, I'm going to put the person on a stomach down, prone position, lay them flat, or maybe lower their head just slightly. If we're talking about the lateral aspect of the lower lateral segment of the right lower lobe, okay, you're thinking about that. Okay, you're going to put them on the left side, right side up, maybe elevate the feet a little bit to use gravity. Okay, so if you understand where the segments are at, you don't have to sit there and memorize all the different positions. This shows you a couple different positions. In the handout in the packet, there's short discussion about not putting the head down. That's kind of the recommendations now, especially with people who have acid reflux, and especially with young children who may not be able to tell you they have acid reflux or understand what's going on. That acid reflux can do more damage to the airways than the actual secretions themselves. So the recommendations now, especially for individuals with cystic fibrosis, is to avoid that head down position. You can use passive, postural drainage, but many times it's combined with chest percussion and vibration. So with chest percussion, you're making your hands into a cup position, you're providing rhythmic forces to help loosen up the secretions in the chest wall, and you might have them incorporate with breathing exercises. And this is before we talked about active cycle of breathing. During that thoracic expansion, you could be doing chest percussion. Versus vibration, your hand is flat against the chest wall. As the person exhale, you're giving a downward motion, you're vibrating, you're shaking the chest wall to help loosen up the secretions. Okay? And then shaking is more forceful, more of a plunging, more of an up and down, basically a shaking sensation to help loosen secretions. So all these can be incorporated with postural drainage. Okay, so how do you bring these together? Well, let's think about this. If a person needs if they're on a bronchodilator, when should they have it? Well, give it to them before the actual postural drainage techniques you're going to use. So work with respiratory therapy, make sure they've had their medications. We don't want to wait until after lunch to do this. We want to do this before lunch or at a point that they don't have a big meal, as you can imagine why. Each position, 5-10 minutes, give a few minutes of percussion, followed by vibration. As the secretions are loosened, they should be doing FETs of different volumes to mobilize the secretions. We can also use air active cycle breathing with postural drainage, combine it that way. Understand the issue of acid reflux. So just educating the person that if you feel like your stomach, you're spitting things up, or you're having some reflux, let me know. If they have aerosol medications like a antibiotic or a steroid that they're breathing in, that's best to do after postural drainage and after percussion because it allows more of the medication to reach the lungs. These are all the things you should be looking for during this. Also in here, I would say watch SpO2, watch heart rate, measure blood pressure, make sure the person's tolerating this. Lastly, there's suctioning. So suctioning is our last resort for removing secretions. We're actually taking a cannula or a tube down into the airways through the trachea, through an endotracheal tube. Even it can be done up through the nose, which isn't the most pleasant way to have it done. We'll talk more about these different techniques when we get to the intensive care unit module, and we'll actually practice it on mannequins in the lab itself. So you will get a lot more information about suctioning later on in the semester.